Hi everyone, welcome to part 2 of this 4-part teaching series. Today we're going to go over some acute surgical pathology. So the aims and objectives, as last time, is to revise some common surgical presentations, to be confident in describing the management of common surgical presentations to the level of a foundation doctor. I know that most of you listening are either medical students or foundation doctors, so I've tried to tailor this approach to be suitable for the level. We're going to revise a bit from session 1, so to practice the management of common surgical presentations using an A to E and a CRISP framework. If you don't know what either of these are, I'd suggest referring back to session 1, and to be able to suggest some key investigations for the common surgical presentations. So I've got a bit of an assortment here. For general surgery, I've got an upper GI bleed, which really is the generic pro forma that you'd use for any major bleed. Abdominal distension, the acute abdomen. For urology, we've got some loin pain, testicular pain, and urinary retention. For vascular, there's acute leg pain, and for ENT, epistaxis, or a nosebleed. I thought it'd be useful to add this in for some quick history taking. So this is a useful mnemonic which can be used after a patient's been stabilised, so after the A to E. So it's AMPLE, where A stands for allergies, M for medication, P for past medical history, L for last meal, and E events leading up to the presentation. For example, you've got a patient coming in with a really bad right iliac fossa pain. You ask them about their allergies, they're allergic to penicillin. That's really, really relevant if you want to start them on some Coamox or some antibiotics preoperatively. You ask for M if they're on any medications. Are they on any anticoagulant medications that you need to reverse? P for past medical history. Have they had surgery before? Maybe they've had their appendix out. That's really, really useful to know. L for their last meal. So when they last ate and therefore when they can go to surgery. And E, events leading up to the presentation. Was it an acute pain that started 2 minutes ago? Was it a pain that's been grumbling for the last 2 months? That will really change your differential. So first, with an upper GI bleed, I've structured this in an A to E approach and sort of what you'd want to do, what you would see as deviating from the norm in issue, and then how to fix the issue. So in A, if the patient is not able to speak to you and their airway isn't patent, in the case of an upper GI bleed, it might be because of blood or secretions obstructing the airway. So how are you going to fix this issue? You want to suction as far as you can see using a Yanker sucker, but you don't want to suction any further. So for C, the patient might have issues such as being tachycardic, having a thready pulse, being hypotensive or very pale, and they might have a cap refill time of greater than 2 seconds. So how are you going to fix this issue? So you want 2 large cannulae in the antecubital fossa. You want to take bloods, so a full blood count, use and ease, LFTs, group and safe if they're going to theatre, cross-match if they're going to be needing a lot of blood, and a coagulation as well. In the case of an upper GI bleed, you might notice an increase in urea. You want to initially fluid resuscitate your patient with IV fluids, so Hartmann's or sodium chloride, but if the patient is losing a lot of blood, the fluid replacement alone won't be enough. So if their hemoglobin is less than 70, for example, on their initial VBG or ABG. In this case, you want to initiate a major hemorrhage protocol. So this is when each trust has a slightly different policy on who to call and what number to call. But in the major hemorrhage protocol, you should have red cells, platelets, and FFP. You also want to reverse any anticoagulation. So how are we actually going to fix the issue? You've given the patient blood, you've taken their blood, they've got cannula in, but you also want to perform endoscopy on any unstable patient with severe bleeding. This should happen immediately after resuscitation. If the patient has a less severe bleed, endoscopy should be performed within 24 hours. So after this, we also want to expose the patient, and we'll go over the differentials for an upper GI bleed in a bit. But with regards to exposure, you might be seeing any potential causes or any indications as to what could have caused the upper GI bleed. So for example, bleeding from other sites, bruising, petechiae, spider nevi, caput medusae, ascites. This will all point towards some kind of chronic liver disease. They might have evidence of trauma and bleeding. You also want to palpate the patient. It might reveal some ascites secondary to cirrhotic liver disease or abdominal tenderness, which would be indicative of an ulcer. It's also important to perform a DRE to see if there's any evidence of further GI bleeding, such as melena. So the causes here, apologies if the font is a bit small, but I've tried to structure it by the height at which we're going down of the GI tract. So starting with the esophagus, the patient might have a Mallory-Weiss tear, which is a tear in the lower esophagus caused by repeated retching and vomiting. And it's common in patients who are alcoholics or who have bulimia or potentially a hiatus hernia. Patients like this will have a history of lots of repeated vomiting. Esophageal varices are another common differential. In this, the patient might have a history of chronic liver disease. And to manage these patients, you want them to go to endoscopy. Before endoscopy, the patient should have terlipressin, which causes vasoconstriction of the splenic artery. But to give terlipressin is a consultant-led decision. It's very important also to do an ECG prior to giving terlipressin, as it can cause ST changes. The patient should also be covered with antibiotics, such as ciprofloxacin, and they should be given endoscopic management, such as banding. You can also give a tube to tamponade the bleed if it's completely uncontrollable prior to endoscopy. However, this is usually something that an ED consultant would initiate. Other issues with the esophagus could be a cancer or an esophagitis that's led to bleeding. With regards to the stomach, you might have a peptic ulcer, which is eroded into the gastroduodenal artery and then causes bleeding. These patients will also need endoscopy and then PPI intravenously for 72 hours following the endoscopy. Patients with gastritis might have coffee ground vomiting, which can appear to be a hematemesis. This is when the blood has been in contact with the gastric acid and then comes out looking like coffee. If there's an issue in the duodenum, it can be due to a post-ERCP complication or a carcinoma of the stomach. So with upper GI bleeds, there's risk stratification and two scores that can be used. So the first one, the Glasgow-Blatchford score, is calculated before endoscopy. And this is used to identify low-risk patients who don't need any intervention. So roughly 20% of patients fall into this category, where they have a score of 0, and these patients can be managed in an outpatient setting. And the Rockall score is post-endoscopy. It can also be done pre-endoscopy, but it's mainly done post-endoscopy to look at mortality and a risk of rebleeding. So our next general surgical presentation is abdominal distension. And your differential for abdominal distension focus on the Fs. So fat, flatus, fluid, fetus, feces, and fatal growth such as cancer. And what we think about in particular is bowel obstruction in a patient with absolute constipation, abdo pain, and abdominal distension. So what we mean by absolute constipation is not passing any feces or flatus. In the small bowel, this is commonly due to adhesions, and in the large bowel, it's commonly due to volvulus or cancer. And to investigate these patients, you want to do an abdominal X-ray and a CT. To manage these patients, you want to keep them nil by the mouth, give them IV fluids and an NG tube. With adhesional bowel obstruction, you want to give the patient gastrographin. This was previously used as an imaging adjunct to help, it can still be used as an imaging adjunct, but it's also both diagnostic and therapeutic, and that gastrographin also helps to relieve the adhesions. If the patient has a sigmoid volvulus causing a large bowel obstruction, they can also be given a flatus tube to decompress the volvulus. However, surgery is indicated in cases of ischemia, a closed loop obstruction. So this is when there's a competent ileocecal valve. So this is a valve between the ileum and the cecum. If this is an incompetent valve, the loop, so that it's not closed, this is almost better, which seems counterintuitive because incompetent sounds worse. However, if the ileocecal valve is competent, then you've closed off that bit of bowel, and that can lead to ischemia. Surgery might also be indicated in the case of hernia or an obstructing tumour, where it needs surgical correction because it's not going to correct itself. And also where there has been no improvement after 48 hours of conservative measures. Thinking about abdominal pain now, I've taken this image from Teach Me Surgery, and it's a good revision as to what could be happening in each of the quadrants of the abdomen. So typically when we look at the right upper quadrant, we're thinking about cholecystitis, but it's important to remember that there are other issues that can also affect this region, such as a low lobar pneumonia or potentially a pyelonephritis. The left iliac fossa, we typically think of diverticulitis, but it could also be a gynecological pathology, a testicular torsion, or a UTI. And the same goes for the right iliac fossa. It's not always appendicitis. There could be IBD causing the pathology or a testicular torsion. So with the initial investigations, despite all the potential differentials that you could be thinking of, they follow the same generic outline. So using a urine dipstick for signs of infection or hematuria. You also want to ensure that a pregnancy test has been performed for all women of a reproductive age, because this will massively change your differential. You could be thinking that you're dealing with an appendicitis when actually it's an ectopic pregnancy. You want to do an ABG, and that's really useful in patients who are bleeding to quickly assess their hemoglobin and see whether you could be going back to our original scenario of needing a major hemorrhage protocol and aggressive fluid resuscitation, or in acutely unwell patients. So lactate is really useful when looking at tissue hypoperfusion. You also want to do routine bloods, and you want to ensure cross-match if blood products are needed. You also want to see if there's an ECG. A patient might be saying, I have abdominal pain, but actually this is a referred pain from an MI. You might want to do some imaging for your patient as well. So a chest x-ray can be useful for any evidence of free intra-abdominal air, so if there's been a perforation, or seeing for a lower lobe lung pathology, so a lower lobar pneumonia. You might also want to do an abdominal x-ray, for instance, to look at any volvulus, or ultrasound imaging. This will be useful in the renal tract, but also useful, so if you're looking for any stones, but also useful when you're looking at the gallbladder, again, to look for stones. And it might also be useful in the liver to see any signs of fat buildup or cirrhosis. You also want to perform CT imaging of the abdomen and the pelvis, and this is really useful for looking for bowel perforation. So the next condition that we're going to move on to is our first ENT emergency. So the red flags that we're looking for in a patient with a nosebleed is a patient who's on anticoagulation, a patient who keeps bleeding despite nasal packing, and a patient who's undergone trauma. The first thing that you want to do, a first aid measure, is sit with the head forward over a bowl or a sink, not backwards. A lot of people will say, to pinch the bridge of the nose and lean backwards, but actually you want them to lean forwards. You want to pinch the fleshy part of the nose firmly and close the nostrils and hold the nose for 20 minutes without releasing the pressure. We also want to encourage the patient to spit out any blood in the mouth. Further management could be cauterization. So if you can see where the bleeding point is coming from, you can use a local anaesthetic spray and then apply some silver nitrate cautery sticks to the bleeding point. If the bleeding point isn't visible, then cauterization isn't advisable, or the cauterization might have failed. So in this case, we want to use nasal tampons to pack the nose. If the nose is packed in primary care, the patient should then be sent to hospital so ENT can see them. If all of this management has failed, then ENT need to take this patient to theatre for potential artery ligation in order to control the bleed. So now moving on to acute leg pain, and what you're most concerned about in these patients is acute limb ischemia. So what you want to look out for are the 6 Ps. So if there's pain, pallor, pulselessness, paralysis, paresthesia, or if the limb is perishingly cold, which is a bit of a stretch for the 6 Ps. What could cause this is a thrombus in situ. So this patient will typically be a classic vascular path. So a patient potentially with a history of smoking or high cholesterol, with a history of intermittent claudication, so pain on walking a specified distance, and atherosclerosis. The plaque in the artery will fly off. So a plaque, for example, in a blocked up atherosclerotic artery will fly off and create a thrombus, and that will block the blood supply to the limb. The contralateral limb, so say if the right leg is affected, the left leg might also have bad pulses and background vascular disease. So you can sort of see both of the legs will look abnormal in this case. Also, the affected leg might have collaterals as the vessels have been damaged for a while. So there'll also be collateral vessels present, which might make the signs look less obvious than they are. Patients also might have an embolus causing this. So this typically won't be a vascular path. It'll be someone with AF, and they'll have a normal pulsatile contralateral limb. So the other limb will be normal, and they won't have any collateral arteries in the affected limb because they haven't had this background of vascular disease. So their leg will look really, really, acute, and they'll have all of the 6Ps and a really pale leg. So what do you want to do with these patients? You want to get to theatre quickly and reperfuse, because there's a cut-off of 6 hours, and after this point, the condition might be irreversible. You also want to perform a CT angiography and give the patient some heparin. If the limb is viable for reperfusion, you've got 2 options. You might have, for embolic patients, you want to do a surgical thromboembolectomy. And for thrombotic patients, you want to first perform thrombolysis and then use a balloon or create a bypass to remove, to open up the artery once this issue is sorted. However, if it's non-viable, so if we can't reperfuse this leg, the leg will be rigid, immobile, mottled, and it's really, really dangerous to revascularize. So if you try and revascularize a leg that's non-viable, all of the potassium that's built up in this dead leg will flood into the central circulation, and essentially you'll have a massive hyperkalemia leading to a cardiac arrest. So in these cases, your options are amputation or palliation, which I suppose underlies how serious this is as a condition. After the acute issue has been sorted, to follow up these patients, we want to perform an ECG, an echo, a duplex ultrasound scan, and they're going to be on clopidogrel and a statin at 80 milligrams pretty much for life. So now moving on to our urological conditions, the first condition to discuss is loin pain. So in the case of ureteric colic. So these patients typically present with severe onset pain radiating from loin to groin. They're unable to get comfortable in any position. It's often accompanied by vomiting, sweating, and they might have hematuria. From experience, some of the patients I've seen with ureteric colic are the ones who appear to be in most pain out of anyone in the hospital. They'll literally be screaming out in pain. The investigations that you want to do for these patients is a urine dip and culture. You want to do their full blood count, CRP, U's and clotting because if any procedures are required. And you also want to do a non-contrast CT KUB. You want to investigate what's causing this stone. So a urine MCNS will be useful, as will stone analysis and looking at their calcium levels as well. So how do we manage ureteric colic? So in the first instance, these patients are in a lot of pain, so we want to give them some IM NSAIDs, in this case diclofenac. If the stone is less than 5 millimeters, it will usually pass by itself. But if it's between 5 to 10, but not over 10 millimeters, we may need shockwave lithotripsy, and that is the first option. So in this case, we have shockwaves to break up the stone into smaller pieces that can pass through the body as urine. An alternative for this might be using a scope, retrograde up through the ureter and into the renal pelvis, where then it can be extracted, so the stone can be extracted, or laser ablation can be used. And this is particularly useful in individuals where lithotripsy is contraindicated, so in pregnant women. So in most cases, a stent will be left in situ for around 4 weeks. If the stone is between 4 to 20 millimeters, you want to explore the same options as above, but bearing in mind that we might have to use a percutaneous method. So in this case, which is what is indicated for stones over 20 millimeters, a surgeon will make a small incision into the back and insert a tube into the kidney and use a scope to remove or break the stone. A tube will be left in the kidney to drain urine. This is particularly useful for removing larger stones. So the next emergency to discuss is urinary retention, and this can be caused by a number of things. Generally, it can be caused post-operatively, so by drugs, immobility, or abdominal surgery. It can also be caused by medications, so anticholinergics, opioids, benzos, antihistamines. And there can also be neurological causes, such as a stroke, a spinal tumour, spinal blocks. Locally, you can have luminal issues, such as a stone or a clot, mural issues, which affect the structure of the urethra, or extramural causes, such as benign prostatic hyperplasia, prostate cancer, a pelvic tumour, a pregnant uterus, or a prolapse. So what is urinary retention? It is the inability to pass urine over a period of hours, which causes severe pain or distress. These patients will have suprapubic tenderness and a potential palpable suprapubic mass that will never be higher than the umbilicus. Elderly patients will have acute confusion. What you want to do is send a urine sample, use an ease, creatinine, and also look for any signs of infection. A PSA is not appropriate in this case. How do you manage these patients? A bladder ultrasound scan will show a volume of over 300 ml, and you want to decompress the retention by inserting a catheter. After this, you can investigate the underlying cause, such as a DRE, or referring female patients to a gynecologist. A key complication here is post-obstructive diuresis. So the kidney will produce lots and lots of urine after the retention has been relieved, and this can be greater than 200 ml in 2 hours, and that can lead to dehydration and electrolyte imbalances. So it's important to replace fluids adequately in these patients and to monitor their use needs. So next, going on to acute testicular pain and testicular torsion. So in these cases, patients will have an acute onset of severe testicular pain, which may be referred to the groin or the lower abdomen. On examination, patients might have a high riding testicle that's swollen and tender, and the elevation of the testes does not relieve any pain. This is a clinical diagnosis. Patients must go to surgery as soon as possible for scrotal exploration and bilateral testicular fixation. This is in the case of testicular torsion, and it's really important that patients go to theatre within less than 6 hours. The next differential for acute testicular pain is epididymoorchitis. So this is infection of the epididymis or the testes and all. It's most commonly caused by the spread of local infections, such as an STI or a UTI. And these patients will have a gradual onset of testicular pain and fever and a leukocytosis. On examination, they'll have a swollen testicle. The elevation of the scrotum relieves the pain, so patients will be friend sign positive. On investigation, you might want to do a NAT test for chlamydia and gonorrhea in patients who are sexually active. But in patients who aren't sexually active, you might want to do an MSU for microscopy and culture. For management, if the organism is unknown, you want to give them IM ceftriaxone stat and 14 days of doxy. If the organism is known, I would suggest referring to microguide or your local microbiology team for the most appropriate antimicrobial strategy.